The 4 principles are the ABCs of bioethics. If you walk into any hospital ethics committee in America, this is the language they are speaking. They are autonomy, non-maleficence, beneficence, and justice. Beauchamp and Childress argued that these 4 principles are prima facie binding, meaning they are always right unless they conflict with each other. And the tragedy of bioethics is that they always conflict with each other. The art of the field is navigating those conflicts. Let's start with the big one. Autonomy. This is the right to self-rule. It is the idea that you are the captain of your own ship. In American culture, autonomy is the trump card. If a competent adult wants to refuse a life-saving blood transfusion, autonomy says we must let them, even if they die. Autonomy requires 2 things: liberty, freedom from external control, and agency, the internal capacity to understand and choose. All our laws about informed consent are derived from this principle. We respect the chooser, not just the choice. The second principle is non-maleficence. This is the oldest rule in medicine, often summarized as primum non nocere. First, do no harm. It is a negative duty. It means refraining from actions that cause injury. It sounds simple, but in medicine, every treatment involves harm. Surgery involves cutting someone open. Chemotherapy involves poisoning them. Non-maleficence doesn't mean don't hurt. It means don't cause unnecessary or disproportionate harm. It is the foundation of all our safety protocols and negligence laws. The third principle is beneficence. This is the positive duty to help. It is not enough to just not hurt you. I must try to heal you. I must prevent harm and promote good. This is the engine of healthcare. However, beneficence is often the enemy of autonomy. When I think I know what is good for you better than you do, I risk becoming paternalistic. If I force you to take your medicine because I want you to live, beneficence, I am violating your right to refuse, autonomy. This conflict is the central drama of clinical ethics. The fourth principle is justice. This is about fairness. How do we distribute the benefits and burdens of society? If we have 1 liver and 2 dying patients, who gets it? Justice demands that we treat like cases alike. We shouldn't pick the recipient based on race, wealth, or political connections. While doctors are great at the first 3 principles, they often struggle with justice because it requires looking away from the patient to the system. It forces us to ask, is it fair to spend $1 million on this one patient when that money could fund a clinic for thousands? So, what's wrong with principlism? Critics call it the Georgetown mantra. They argue it is too abstract. It gives you a checklist but not a solution. It tells you that autonomy conflicts with beneficence, but it doesn't tell you which one wins. There is no built-in hierarchy. Furthermore, critics argue it has a massive Western bias. It elevates individual autonomy above community harmony. In many Asian, African, and indigenous cultures, the family or the community is the unit of decision-making, not the isolated individual. Exporting American principlism to global health can sometimes be a form of ethical imperialism. Because of these failures, we need alternatives. One is communitarianism. This framework argues that human beings are not isolated atoms. We are socially embedded. Our individual rights are secondary to our responsibility to the shared life of the community. Public health ethics relies heavily on this. When we mandate masks or vaccines, we are using communitarian logic. We are saying, your autonomy stops where the community's safety begins. It is a corrective to the hyper-individualism of American bioethics. Another alternative is casuistry. This is case-based reasoning. Instead of starting with high-flying principles, top-down, You start with the specific facts of the case, bottom up. You look for paradigm cases, clear examples where we know the answer, and you reason by analogy. It is very similar to how lawyers use legal precedent. You ask, is this abortion case more like a privacy case or a murder case? Casuistry is messy, but it is practical. It helps us muddle through moral disagreement without needing to agree on a grand theory of the universe. In the real world of policy, you will mix these frameworks. You will sound like a principlist when writing a patient's Bill of Rights, emphasizing autonomy. You will sound like a utilitarian when writing a budget, emphasizing efficiency. You will sound like a communitarian when writing a quarantine law. The skilled analyst knows which tool to pick up for which job. The danger comes when you try to use the wrong tool, like using individual autonomy to solve a contagious disease outbreak. That is how you get policy failure. To conclude, Lesson 2, the 4 principles are your starting point, but they are not your destination. You must understand autonomy, non-maleficence, beneficence, and justice, so you can spot the conflicts, but you must also be ready to switch to communitarian or casuistic thinking when the principles run dry. In the next lesson, we will leave the ivory tower of philosophy and descend into the swamp of politics. We will examine the U.S. health policy ecosystem, federalism, and the chaotic machinery that turns these values into laws.